Yeah, we're live now.
Well, good morning, everybody, to this morning session. This is the Khatib Khan Health Hour. So this is a session that is designed for you, for help when health professionals come and tell us more about things regarding our health. This is a program that is designed for you to help you to be able to look into deeper details about how we can improve ourselves. And we look at different topics and we try to get our own ethnic doctors to come out and do this presentation. My name is Joseph. I'm a GP based in Rochdale. I'm also the mental health lead for Khan. Today, we have a very, very exciting and important topic. We have a distinguished speaker who has delineated himself in his specific field. We will be talking about hepatitis and what it means to us. So it's with great pleasure today that we have Dr. Irvine. Dr. Irvine is a clinical research fellow, Irvine Mangawa. He's a clinical research fellow in infectious disease at North Manchester General Hospital. His specialty involves HIV and other infectious disease and how to develop vaccines for other things. This is going to prove to be a very enlightening topic. So I want to encourage you, if you have questions, if you have burning topics, things that you want to share, please pen them down. There will be a time for question and answers. And if you're watching on YouTube, please feel free to ask those questions, or via Zoom, drop a question in the chat. Without further ado, I'll pass you on to my colleague, Dr. Mangawa. Thank you so much, Dr. Mangawa.
Thank you so much, Joe. I really appreciate with your warm introduction. And thank you, Khan, for this platform for us to discuss health and meet up with our community, raise awareness. I really appreciate this great initiative. And it is an honor for me, really, to get this opportunity, speak with the community. I'm really happy to be here. This is just amazing that you're doing. So without really wasting much time, I'll go straight into the presentation, and I'll just share my screen there. Joe, once you see my screen, you can just confirm that you can see it. Right. So basically, we'll be talking about hepatitis B. And by the end of the presentation, the aim is really to raise awareness regarding hepatitis B. And I hope that people can appreciate how much of a burden, disease burden, is there globally and also within UK, and how much as people of African and Caribbean ethnicity, we are affected by this disease, hepatitis B. So the numbers are quite staggering. I think if you are going to get anything from this presentation, it is how many people are being affected by this. Joe, can you just confirm that you can see my presentation? I guess everyone can see it now, right?
Yes, we can. Yes, we can.
Thank you so much. Now, so like you said, I'm a clinical research fellow at North Manchester General Hospital, and I'm in the Department of Infectious Disease. So these slides were actually made by my colleague who was making a presentation for a community, a Chinese community. So she tells me that these slides, the design of the slides is actually inspired by Chinese, but I think I like them, and I think they could actually still be quite relevant, and probably you find them nice as well. And I like the colors. So what is hepatitis B? Or what is hepatitis? Hepatitis generally is inflammation of the liver. That's hepatitis. Now, inflammation of the liver could be because of many things. But today we're just going to focus on a virus which was discovered in around 1967. And this virus is called hepatitis B. So it infects the liver, causes inflammation of the liver. But more than just inflammation, hepatitis B virus can, if left untreated, left on its own, it can cause scarring of the liver. It can cause, which we call cirrhosis. It can cause liver failure. That means the liver cannot do its purpose of metabolizing food, of making proteins. It can cause liver cancer. And the moment you say cancer, no matter what type of cancer it is, to many people, that's a scary thing. But what is also quite staggering about hepatitis is the number of people globally that are living with hepatitis B. It is estimated by WHO that we've got 300 million people affected by hepatitis B. Now, to put it into perspective, I want to compare it with HIV. HIV only has around 36 million people, around 36 million people, probably who are currently on treatment. And we have got around 300 million people with hepatitis B. Now, and we've got around 1.2 million new infections each year. This is according to WHO, and this was 2022, 1.2 million new infections each year. And it's almost similar to HIV as well. Now, in terms of deaths that are related to hepatitis B, mostly through cirrhosis and liver cancer, we have almost 1 million deaths each year due to hepatitis B. That's quite a lot of deaths. And with HIV, we've got around 600,000 deaths. So that tells you that we've got a lot more disease burden coming from hepatitis B. We've got a lot more new infections coming from hepatitis B, and a lot more people are dying of hepatitis B as compared to HIV. Now, hepatitis B, we call it a blood-borne virus, right? So it means it can spread through exchange of blood and fluids, just like HIV. And so contact with infected blood, it can be spread by sexual transmission, just like HIV. It can spread vertically from an infected mother to a baby. So that's vertical transmission. But there's probably one form of transmission that I should have mentioned there, which is actually horizontal transmission, which happens with people within the same household. People that are sharing the same sharp instruments within household. That's why whenever somebody has got hepatitis B, we somehow also want to screen their household as well. So you're sharing sharp items like nail cutters. So hepatitis B can actually spread that way. But it is also very important to mention that hepatitis B virus is not spread by sharing food, by just mere using of utensils like a spoon, by physical contact, for example, hugging, kissing, or breastfeeding. So it doesn't spread that way. Unlike HIV, HIV can spread via breastfeeding, but not with hepatitis B. And this is now just trying to zone in to our community. That is the African Caribbean community. So this is the global map. And I took this from CDC. The darker areas there actually tell you where the most disease burden is. And you can see that it's Africa region and parts in Asia. And it is estimated that Africa only has probably around 60 to 70 million people with hepatitis B. Nigeria, which is the biggest population in Africa, has around 16 million people with hepatitis B. That's almost the population of Zimbabwe, where I come from. The whole population of Zimbabwe, place it in Nigeria, and they've got hepatitis B. That's a huge amount of people. And that's very worrying, really. And you can see that it's mostly the whole of Africa that is affected. The white parts that you can see in Africa, it's just that we don't have data coming from those areas. But probably the whole of Africa is almost as green. But you can also see West Africa. It's almost like the whole of West Africa, it's dark green. And that's a higher prevalence that is more than 8%. And from a report that came from Clinton Health Access Initiative, they say that the majority of people with hepatitis B, they don't know actually that they have hepatitis B. So they are going around with hepatitis B and they don't know it. Only around 10 to 25% know that they have hepatitis B. And only around 2% are actually on treatment. And globally, we are speaking of around 60 million to 70 million people who should be on treatment, but they are not on treatment. What does that mean? It means they can easily spread out hepatitis B. So personally, I feel hepatitis B is one of those infections that are not talked about as much as we talk about other infections like HIV, like COVID. We saw how people panicked when there was COVID. But again, hepatitis B is one of those conditions that can easily be prevented. And you'll soon find out. Now, when we talk of hepatitis B, there is acute infection and chronic infection. Now, acute infection, basically, somebody gets infected with hepatitis B. There is inflammation, and they're able to clear it. That means it gets out of the body. They are healed. They're okay. They're fine. Sometimes our immune system, they cannot cope with the virus, and it stays on. And we end up having chronic hepatitis B. Now, age is the greatest or the most important risk factor when it comes to hepatitis B. That means the younger you are, the likely you are going to develop chronic hepatitis B. So if you are infected as a newborn, there's a 90% chance that you become chronic hepatitis B. But if you are infected in adulthood, there's less than 10% that you actually develop chronic hepatitis B. Basically, what it means is that in older age, the immune system would have developed enough to deal with this complex virus. So that's why it's very important to actually deal with hepatitis B at a very early age in childhood. Now, how do I tell that I've got chronic hepatitis B? Hepatitis B is always silent. In most cases, it is silent. It doesn't give up symptoms until at a later stage when you start having cirrhosis, that is scarring of liver, like I said. So it's very silent. So you need to go to your GP, ask for testing. Now, in the UK, for example, there is recommendation that when somebody is new in the UK and they are coming from a high-risk country, they must be screened for hepatitis B. So if you're coming from Africa, from West Africa, from any part of Africa, and you're registering with GP for the first time in UK, you should actually be screened for hepatitis B. But sometimes people are missed. Sometimes people don't register with GP And there are many other things that people are missed by the system. If your blood tests are negative for hepatitis B, you can be vaccinated. So there is a vaccine for hepatitis B, and it's very effective. And if you are found to have chronic hepatitis B, you need to be referred to a specialist. So if you're in Manchester, you get referred to our system at North Manchester Hospital. But not everyone with chronic hepatitis B needs treatment, but everyone needs to be monitored, and I'll share with you. So we've already talked about hepatitis B being chronic, and that your body cannot get rid of it. That's why you've got the virus still, stuck within your body. And it doesn't have any symptoms unless you start having cirrhosis, which is scarring of the liver. And that process from infection, getting to chronic hepatitis B, and getting to cirrhosis or liver failure or liver cancer, it's a long process which takes so many years, sometimes 30 to 40 years. But for some people, they can be unfortunate and they can get it within 10 years. And again, like I said, if anything, if you are going to forget anything that I've said, don't forget that hepatitis B is a huge thing in terms of numbers. So if you're someone who is concerned about population health, in UK only, around 180,000 to 200 people, some actually put it around 200,000 people estimated to have chronic hepatitis B. And sometime in 22, we did an audit of all the people that are coming into our clinic with hepatitis B. So that was over a period of 6 months, 700 people coming into the clinic over a period of 6 months. And almost 40% of them were of African and Caribbean ethnicity. And over 95% of people with new chronic hepatitis B infections in UK are migrants who acquired infections in their own country of birth during early childhood. So it is more of reflecting migration patterns in UK. So people get infected while they are in their original countries, and they come to UK and they get missed within the system. Then later on, they've got cirrhosis. So I've talked about cirrhosis, and just to add in some nice pictures there, but there's nothing nice about liver cirrhosis or liver cancer as well. But something to highlight about liver cirrhosis or the scarring of the liver tissue. Sometimes it doesn't show any symptoms at all. You could be walking, having your normal day, normal life, but your liver is scarring. And sometimes liver cirrhosis can progress to liver failure, and it is a risk factor to developing liver cancer. Now, these are the extreme symptoms, really. When your liver is now failing, how do you see that? What sort of symptoms and signs do you actually get? Jaundice, which is yellowish eyes. Sometimes you get that in acute infection, but it usually clears off and goes away. But you can see it in liver failure, and it's always there. There is swelling of your abdomen, and it gets filled with fluid, a condition that we call ascites. Sometimes you can get confusion, poor memory, because there are certain chemicals that go into the brain and affect the brain. And if liver fails, the only option is actually a liver transplant. So once you lose your liver, you have to get another liver. And where do you get another liver? That's the thing. Now, like I said earlier, hepatitis B infection prevented by vaccination. If all countries in this world are going to have an effective program of vaccination, then the world can get rid of hepatitis B. That's as simple as it can get. We need to make sure that everyone gets vaccinated. Our relatives, they need to know about this. And the minimum number of injections that are needed is 3. And usually they are given during birth. Most countries now, they have got this regime in place. Just walk into a clinic, get 3 injections. It's safe and it's effective. Who should be vaccinated? Spouse, children, family members, household contacts of person with chronic hepatitis B. So somebody has been screened. We now know that they've got hepatitis B. They need to bring in their family. They need to bring in their household contacts. They need to be vaccinated if they need to, if they haven't been vaccinated. And all babies of infected mothers, they need to be vaccinated at birth. That is in the UK. And it's also true in other countries. Now, in this section, I'm going to talk about the treatment, service, and care. If somebody has been treated with chronic hepatitis B, what needs to be done? Like I said earlier, get referred to a specialist who looks at the hepatologist, who look at the liver. Sometimes you get referred to an infectious disease department like North Manchester. And there are a number of tests that needs to be done. But also, your GP has to arrange for all your contacts, that includes sexual contacts as well, to be screened. That includes your partner and your partners, children, household contact. We've already mentioned things like that. And in UK, they also have extra support as well. So the specialist will have to take a full medical history. They need to take an alcohol history, because alcohol makes your liver condition worse, especially if you've got hepatitis B. So they need to know about alcohol history. They need to know family history of cancer, because it runs in the family. So if you've got your family descendants who have had liver cancer, so there is a greater risk that one may also have liver cancer. You need the examination, blood tests to be done. Now, in terms of blood tests, I'll just mention a few here. We are looking at really liver enzymes that can help us with, in terms of getting the levels of inflammation. Then there's what they call hepatitis B viral load. They've got hepatitis B surface antigen. They also have to screen for other blood-borne viruses. That includes HIV and hepatitis C. Then there are also some markers that can tell us whether there is a likelihood of liver cancer. So like things like alpha-fetoprotein. But there are also many other tests. Ultrasound of the liver. This can help us to measure the size of the liver. But in terms of scarring, they can do a fibroscan. That can help us with measuring how much scarring has happened to the liver. And sometimes if there is scarring and there is need actually to evaluate it further, you can be taken to a hospital to do a liver biopsy, which is actually taking a small tissue from the liver and look it under microscope. Now, in UK, there are treatment guidelines in terms of who to treat for hepatitis B. So like I said earlier, not everyone is put on treatment when they are diagnosed with chronic hepatitis B. So your doctor has to do the test. They have to check the viral load. They have to check inflammation of the liver using the liver enzymes. They have to check the hepatitis B surface antigen level as well. And sometimes they have to repeat those bloods and just to see what's the trend over 6 months. And if there is really conviction that there is inflammation, for example, that the hepatitis B viral load is more than 2,000, it's more than 20,000, you may be considered for treatment. But they also consider the age. And like I said, levels of scarring and inflammation, the liver enzymes. So not everyone goes on treatment, but that's upon assessment by a doctor. Now, I'll talk about the treatment options that are available. Like I've already mentioned about the NICE guidelines. And in terms of the first line for treatment, we've got the pegylated interferon. So these are injections which you can self-administer, and it's given over 48 weeks, every week, getting an injection for 48 weeks. Now, these injections, they've been seen to be quite effective and in some cases be able to clear hepatitis B. But that's to a very small percentage, something like 10%. So in about 10% of the people, it has been noticed that it can actually result in clearing of the hepatitis B, but not for the majority of the people. So the aim basically is actually to reduce the amount of inflammation that happens to the liver. That's the main aim of the treatment, just to reduce the inflammation. Otherwise, the virus will stay on for a very long time, if not forever. Now, there are also some other tablets that can be given for hepatitis B. We have got tenofovir. So these are, in short, we call them NRTI. It's non-nucleotide reverse transcriptase. So it's the same treatment that is given for HIV. But this time around, they don't give the combination medication like they do in HIV. It's just one tablet, tenofovir. The other one is called entecavir. It's just one tablet that you take every day. And it's very good tablet, very tolerable. Unlike the pegylated interferon, the pegylated interferon can cause a lot of side effects, and it can be intolerable to some people. It can cause fever, nausea, vomiting. It can cause mental health, depression, and all that. So pegylated interferon, many people, they don't tolerate it, but tenofovir, many people are able to tolerate it. Of course, there are a few things that need to be monitored when you're taking tenofovir, things like renal function, because it can affect renal function. So people need to be followed up in terms of their renal function. I've already mentioned about the treatment side effects of pegylated interferon. And I've already mentioned as well about tenofovir. Now, so basically we have covered the main treatments in terms of what is available in UK: pegylated interferon, tenofovir, and entecavir. So very few options really. And these options, they are not there to cure hepatitis B. They are there to reduce the inflammation that happens through the liver, and they reduce progression towards scarring of the liver, as well as developing liver failure and liver cancer. Now, in terms of treatment, this is probably my last slide. Like I said, current treatment, they control rather than cure hepatitis B. and they prevent serious liver damage and cast the risk of developing liver cancer. But even if not started on treatment, you need to be monitored every 6 months to see if disease is becoming active and to check for liver cancer. So every 6 months, if once you have been diagnosed with hepatitis B, every 6 months in UK, you must be followed up, even if you are not on treatment. So this is where I've noticed that people of our ethnic background, they get missed out because they say, I've got this condition, but I'm not receiving any treatment. Why do they ask me to come to hospital every 6 months? If I'm not getting anything, just to take my bloods, why should I come? Why should I waste my time? They need to follow up so that once your liver begins to fail, they can easily identify it. Once you're moving towards liver cancer, they can easily identify it. Once you're moving towards liver scarring, they can quickly identify it. And you get on the treatment. So every 6 months, you need to be followed up, even if you are not on treatment. But in North Manchester, we also have current trials that we are doing, where we are looking into cure for cure for hepatitis B. So there are trials that are happening, and we have 2 trials for hepatitis B at the moment. And all I can say for now is that what we are getting from those trials, it's quite promising, very promising. But these are just research, still at research stage. It may take a number of years before we get those treatments licensed and be available for everyone. But yes, there is ongoing research. And so for those who probably be interested in research in terms of hepatitis B and its cure, probably you can actually contact us, North Manchester General Hospital Infectious Disease Department. Probably you may be interested in participating. And this is also something that I would want to encourage people of African and Caribbean backgrounds to get involved with clinical trials. If a new drug has been tried in people that have almost similar genetic makeup with you, then we are sure that it's probably going to work to people of the same ethnicity as well. So I know that there are quite a number of people that are quite suspicious of clinical trials because they think that they're being used as guinea pigs. But to be honest, if there are no people that volunteer to participate in trials, then we don't get to have new treatments being developed. Most treatments, I would say, of course, they are being developed in here in Europe, and but the best that you can do is actually to volunteer to participate in clinical trials. And at the moment, I would say, unlike in the old days, clinical trials these days, they are happening in a much more safe environment where it's very much controlled. There are ethical levels that you have to, that ethical guidelines, I should put it that way. There are ethical guidelines that should be followed. So it's no longer like the old days when, doctors would just do anything. But I think we are now working in a more professional, more ethical environment. And people shouldn't be very skeptical of clinical trials these days. So probably that's my ending message there in terms of my presentation today with hepatitis B. I hope I've managed to raise the awareness. I hope I've managed to make you know that there's a lot of hepatitis B going around. And if you have never been screened for hepatitis B, you probably should be screened for hepatitis B. Approach your GP and get tested for hepatitis B. Thank you. I'll hand over back to Joe and the team. Thank you. I'm going to
Thank you, Dr. Irvine. Yep, thank you. That was quite enlightening. quite a few points to note there. I'm just going to add you to my picture if this will allow me to. There we go. Right, hepatitis B. I think you hit a lot of highlights there that were really, really important. And like I was saying before the program started, while I was in medical school, I lost a beloved teacher and lecturer to hepatitis B. So it's quite personal to me in terms of the effects that hepatitis B has. And already we have a few questions that are in the chat boxes. Please feel free to ask your questions. This is now time to ask questions. One very good question immediately that comes up is, can somebody who is fully vaccinated still get hepatitis B?
Thank you so much, Joe. So, like I said, once somebody is vaccinated, the effectiveness of the vaccinations that we have in the system at the moment, we are talking of almost 100% effectiveness. They are quite good. I would say there is, well, you can never say never, but I would say there is very slight chance. I would probably rule it out in real sense, rule it out, but you can say never, never. But yes, these vaccines are quite effective. These chances are very slim that you can still get hepatitis B. And mind you, once you are vaccinated, your body now has antibodies that can fight against hepatitis B. So your system now is trained to fight hepatitis B virus. So it's quite difficult really to actually get the virus after being vaccinated. But you need probably to get checked for vaccination for hepatitis B antibodies here and there. I know that whenever, for example, if you're going to get a new job, let's say in NHS, they'll always test for your antibody level.
Yeah.
And this antibody level can tell them whether you still need another booster dose for hepatitis B. But it has been found that getting only a minimum of 3 doses should be able to give you lifelong protection. But we've got people that have probably received 1 or 2. And so in such cases, probably you put yourself at risk. But once you get 3 doses, you should be okay.
Excellent. Thank you for that. So just again, while you were presenting it, I was a bit curious to the fact that you mentioned that hepatitis B effectively affects 10 times more people than HIV does. So why does HIV get so much press and hepatitis B is not really spoken about?
Exactly. I think that's a very good question. And it also worries a lot because hepatitis B, one, is affecting a huge population. It's just, causing as much death as, HIV, and people need treatment as much as HIV. But sometimes it's difficult to understand how things happen and how the global world operates. But one of the things is that when people speak a lot about hepatitis B, then we create an agenda for hepatitis B on the global platform. We create an agenda for hepatitis B on the political platform. We create an agenda for hepatitis B on WHO platforms. So it's a problem that is bigger than us as individuals, but something that probably we need to use our platforms like these ones to raise the awareness so that people know actually that these are the challenges that we have in terms of hepatitis B. And the more people speak about it, the more people realize that actually we are as much affected with HIV than hepatitis B than HIV. So it's more of awareness, like we said. And again, probably in training, even myself in training, I remember we used not to talk a lot about hepatitis B. As being trained as a medical practitioner, it's not something that we talked a lot about, yet it's something that is affecting many of our people. So it's all about awareness. It's all about, speaking about hepatitis B on every platform that we get.
Thank you for that. I mean, like you said, I think it's a global thing where, the awareness is just not there, which is why we're probably having to do a session like this today. A similar question to that is, I'm kind of like trying to finish a certain group of questions before we go to another group of questions. Does hepatitis B, like for like, does it kill more people than HIV? Or, is it more, how will I put it now? Is HIV more easily contracted compared to hepatitis B?
Yeah, so in terms of transmission, so hepatitis B is easily more transmissible than HIV. So I think there is, especially in clinical settings, I think there is actually a study that was done in a clinical setting, and they say it's the risk of getting HIV is 1:300, but for hepatitis B, it's 1/3. So there is
that's quite impressive.
You can easily get hepatitis B than than HIV. Actually, that's definitely one thing. I think you raised the other question that you raised was the other second part of this question.
Yes. So in terms of looking at the two viruses, which are, quite similar in terms of how they're both infectious diseases, they're both sexually transmitted, are we then saying that hepatitis B is not as serious an illness as HIV? Or is it just that it hasn't attracted the press enough? Because going back to the original question I asked you, I was just thinking back now, in terms of why is it that HIV was more popular? And if you remember, back in those days, a lot of musicians and celebrities contracted HIV. And so it became big news. So if you remember Magic Johnson, who used to play basketball, he popularly had HIV. There's one or two people was rumored that the lady who composed this song, I don't know if it's true or not, Cyndi Lauper, Girls Who Want to Have Fun, I think she had HIV and died. So that just blew up the whole conversation around HIV. So I was wondering, is it that HIV is more of a deadly killer compared to hepatitis, or is it just got more press?
I think it's also to do with how much time HIV can give you before you get to a point where things are really bad. So like you said, with hepatitis B, you can have no symptoms and you can live with it 30 to 40 years before actually one gets to, say, liver cirrhosis, like that. But probably you don't have that much time with HIV.
I see.
So that could be one of the reasons why HIV has got there's so much talk around it. But the other thing also is because HIV lowers your immune system, probably you've got so many other disease conditions coming in as well. And people tend to worry about all those other conditions that come in with HIV. Yet in case of hepatitis B, it's just hepatitis B. It's just you and hepatitis B.
That's a really good point.
Yeah.
So a similar question, that if you have autoimmune disease, like lupus and autoimmune thyroiditis, can you still get hepatitis? Can you still get the vaccine if you've got an autoimmune condition?
Okay. So I'll probably need to refer that question probably to someone who is more specialized in that area in terms of autoimmune diseases and probably endocrine diseases. But as far as I know, I don't know any contraindications in terms of getting the vaccine.
Yeah, there isn't any. There isn't any. Worst case scenario is that people with autoimmune conditions may require more of the vaccine in order to get the uptake, but they can get the vaccine. Caroline asked that question. I know for a fact because I did do some work back in the day with infectious diseases. In terms of, and autoimmune conditions are quite common in the Afro-Caribbean community as well. In terms of you mentioned about clinical trials. I want to get a little bit political here because this is something that's close to my heart. During the COVID vaccine and trials and things, now I was approached by, Khan was approached by to help promote the idea of people going for research trials. Do you know what the numbers were for Black ethnic minority who went for clinical trials?
Right. So you mean in terms of working or participating?
Participating.
As participants, volunteering to participate in a clinical trial.
Yeah.
Now, the numbers are very low, I should say. Just learning from our site only, I would say it's a bit of a challenge to get people of African ethnicity into clinical trials. Of course, there are some that we have, but the majority we have, especially for new treatments, novel therapies, the majority are actually other ethnicities. But I would put it probably a percentage and say at North Manchester, 90% are actually of other ethnicity groups, people that have accepted to volunteer.
Why do you think that's the case? Why do our people not, come out and go for clinical? What are the reasons that you see?
Well, it's on many things, really. I'll put it on many things. Because we did just as an audit to look at this. One of the things that we discovered when we actually in an audit that we did in Hepatitis B clinic at North Manchester, one, doctors themselves, they don't approach their patients to discuss about research and clinical trials. So there is a little bit of gap in terms of information get to the to the participants, and we also noticed that there was also challenges in terms of language.
I see.
Because consent forms, they are usually come in English. So if you're going to consent someone to participate in a study, you want someone who is going to understand the consenting process very well. Sometimes you don't get translators. So it can bias even those who are going to recruit for trials to say, probably let's just go for someone who speaks fluent English because we're going to understand one another. But there's also an element of saying within the African community, there are a lot of conspiracies and skepticism around vaccines as well, and participating in trials. And the moment that a clinician mentioned that, would you like to try a new treatment? Possibly they are likely to say no.
Yeah.
But it's difficult really to point it out and say it's due to this. This is just me postulating and just saying what I think.
So basically, it's a combination of factors, isn't it?
It's a combination of factors, really.
It's several things. It's not one thing.
It's not one thing, yes. So sometimes the message is not getting out into our African community enough. It's not getting there. They are not getting the information. If they were getting the information, probably they would participate.
So this is another reason why we need platforms like CAN to help to bridge the gap, within the health inequalities and, to get the information out there. It's ironic. This is me being a little bit cynical. So, and it's not a question, it's a comment. So Afro-Caribbeans don't like participating in clinical trials, yet we turn around and criticize the vaccine when it's done. So the question I'm asking is, where were you when the vaccine was being developed? You could have been part of the whole process.
Exactly.
But now we turn around and say, oh, we're suspicious of that, and then, people don't. Somebody's put a question here. Are there protective interventions for a pregnant mom from infecting her child if they have hepatitis?
Oh, yes. So through antenatal care, you can actually get follow-up. They can monitor you closely in terms of the inflammation and whether you need treatment. So number one can get treatment. But the second thing is that there are some immunoglobulins or antibodies that can actually be given during delivery to actually reduce vertical transmission. So this can be given based on the birth weight of the baby. Then with close follow-up after delivery, the baby can also receive some vaccinations.
Okay, thank you for that. Yeah. That's great to know. Someone's got his or her hand up. I think that's Caroline. Can you unmute yourself?
Yes, thank you. I just wanted to say also, I think there's a lot of fear in terms of, probably you guys touched on it, the fact that we don't really know what they're doing. We don't understand the medication they're going to be given. It's not really explained because, for instance, I've got the autoimmune disease called sarcoidosis. And I was asked if I wanted to do the troweling, and they gave me this sheet of paper, and then that was it. The first thing that popped into my mind was, well, I'm not going to be a guinea pig because I don't know what you're going to be giving me. For one, I don't know if it's going to make the situation worse. You talk about a placebo, and also, I mean, there's a lot of wording in there. It's not like someone sat me down and just, really explained it like they would if you have. If you've just been given a diagnosis of something where they go through it with you. Even my diagnosis of this it was literally, you've got this, take this, and off I go. So I think, in our Black community, this is not something we do because we always think about herbal. We always want to go in the side of herbal because we think it's less dangerous to our body. So I think it's just lack of understanding, and this really does help. Because even though I worked in the health field, I didn't really understand Hep B, Hep C, Hep A. I just knew that I had to have the injection just so that I don't get it or I don't pass it on if I had it. That's all I knew. So this really helps for our community to actually, get on the program to be able to, say that I want to do the clinical trial. Because if we don't get it, I think at the end of the day, we suffer the most. Because Black people just, so
Absolutely. Thank you for that, Caroline.
That's a very important point, Caroline. You've raised it. So this is how actually we do clinical trials. When we come across somebody who is interested in clinical trials, we give them what we call the patient information sheet, where they're going to sit down, go through everything about the trial alone, without the doctor, without anything. And they come to us maybe 24 hours or 48 hours later. Then we explain the study to them. Then I can imagine, like what you said there, probably somebody sitting down with their PIs and they are reading all that. And they are actually having more questions than answers going through the PIs. And probably, it's something probably that we need to have a look in terms of how we actually approach participants for studies. Probably we can have a different approach that doesn't scare people away. Because the PIs can be very big, maybe 20 pages for one to go through about a clinical trial. And they've got full information, and some of the information can be quite scary and all that.
Yeah, so even for me, that's a doctor, if you give me anything more than 2 pages, I'm not going to read it. You know, I said that to, I had a bank thing once, and the guy he was going to send me some documents. So I said, what's the summary of this document? Tell me the whole thing. I don't, because if you send me all this, tell me the important. The guy started laughing. Because I told him I'm not going to read it. So I think, Caroline, excellent contribution there. And Irvine, you know what? We need to do better, not just in terms of how we explain things to patients. And this cuts across the board. I'm a GP. Most of the time, half of my consultations, people have been to hospital. They've had a procedure done. No one's explained anything to them. And then they come back and make an appointment with me. We don't understand why they put a camera through my nose, my ear, my left leg. They just said, you are sick, get on the bed. Obviously not like that, but you get what I'm trying to say. And they need more explanations. And so I think we need to do better. There's a point that Caroline raised in terms of, and I know we're running out of time. There are different types of hepatitis. So we've just talked about hepatitis B today. There's hepatitis A, there's hepatitis C, hepatitis D. Do you want to shed a bit more light on these other hepatitis, just in 30 seconds on each of them?
Okay. Yeah. So, like I said, hepatitis is inflammation of the liver. But we've talked about hepatitis B. But there's also hepatitis A, hepatitis C, hepatitis D, and hepatitis E. Now, these are different types of viruses. And they've got different types of actually mode of transmission.
Mode of transmission is the main thing, isn't it? Yeah.
The hepatitis A is usually oral fecal route. So somebody ingests something or drinks something with hepatitis A, but not so much for hepatitis D, hepatitis C and D. Now, I'll start with hepatitis D because hepatitis D is very close to hepatitis B, and it happens either as an infection on top of hepatitis B or together with hepatitis B. So what we call like co-infection or super-infection. You don't have hepatitis D without hepatitis B, because hepatitis D it survives on the presence of hepatitis B.
Right.
You clear hepatitis B, you lose hepatitis D. Then hepatitis D is another blood-borne virus again, and this one, hepatitis C, we talk it combinedly with hepatitis B and HIV, and there is treatment actually for hepatitis C. Then, of course, there is hepatitis E.
Sorry, hepatitis C, is that the one you get mainly with drug users and people who inject?
Exactly. With the drug users, hepatitis C.
So it's mainly like a needle type transmission type thing, unlike hepatitis B, which is also sexual.
Yes, yeah. Tattoos as well.
So you know what, and tattoos. Yeah, you know why I was bringing it up, because there was a point in time about 2 years ago where we had a lot of patients coming from, and I'm not scaring people, but coming from Morocco, Egypt, and they had a lot of hepatitis A. They didn't know what the symptoms were, but they came with these things. And by the time some of us who had knowledge of infections, we began to screen them, and a lot of them were coming positive for hepatitis A. And it was mainly due to unwashed or poorly processed fruits and things, because these guys they're not washed there. So please be careful when you travel to certain countries. You have to make sure you wash your food. But hepatitis A does not kill anybody. It just gives you a bad,
it goes
diarrhea, and it goes away by itself. But
yes,
potentially, it's something to think about compared to, all the other different hepatitis. So it's very interesting actually when you think about diseases and the things that can happen to people. There's a lot that we don't know. Like Caroline was talking about the fact that she had this autoimmune issue and all of that, but there's a lot that we can do. I just want to use this opportunity once again to just advise people, please go and get help from the right sources. Don't assume anything. Don't assume that, I know or have an idea and things like that. Please, let's make sure that we get the right information. My favorite phrase is that you do not take your Volvo or your Audi to a bicycle repair shop. All right. Nobody takes their Peugeot, Toyota to a bicycle repair shop, because you need to take it to an auto mechanic who will actually know what they're doing. We look at especially some of you men, you look after your cars more than you look after your bodies. We pay more attention to things. It's funny to me. I don't know what you think about it. This is on a lighter note. I don't know. Do people come to you like they come to me and say, I've read on the internet, and they think that because they've now read on the internet, they now have a medical degree. And so they want to tell you about how they think their treatment should be. Do you get things like that with infectious diseases?
It does, and it happens everywhere, where people have gathered information somewhere else, but they've probably not understood it very well, and they approach you with their misinformation, and probably they stick to their misinformation more than any other information that you would probably give to them. So it's actually a challenge in the health field. And I was actually talking to somebody. They are saying there's so much flu going around in Zimbabwe at the moment. And they actually think that when you go to hospital, they are giving people a certain injection, and that's what's making people worse. So they would rather stick to that sort of thinking than whatever you're going to explain to them. Yeah, so it's a challenge. But the more we give information, the more we give the correct information, because whenever the information is not shared, then people try to look for other ways to explain what's happening to them. Yes,
absolutely.
Yeah.
Brilliant. So do we have any more questions coming up as we look to round up? It has been a rather enlightening session today, because this is something that is really, really relevant to us on a day-to-day basis in terms of, and just to cap some of the things, just to mention, you mentioned about the fact that hepatitis B is not curable, right? But there is a vaccine that can prevent it. Is that correct? You mentioned that it's a viral infection and it attacks mainly the liver and can cause inflammation of the liver. You mentioned the fact that that inflammation can go on and cause scarring, which we call cirrhosis. It can go on to cause chronic liver failure. That's the liver itself stops working. So you can see that this is really important to all our different things. We mentioned about the modes of transmission. You mentioned about the fact that it can be sexually transmitted. You can contact it through blood-borne things like blood, IVs. There was one thing I wanted to pull you up on. There's a lovely word in public health called fomites. Now, fomites are mediums of transmission, how you can pass this infection. And I read this somewhere, I don't know how true it is. Apparently, unlike HIV, which outside of the body dies within 24 hours or 48 hours or so, apparently hepatitis B can stay on a doorknob handle for up to 2 weeks. Is that correct?
That's correct. So hepatitis B can stay longer, and probably that explains partly why there's higher risk of actually getting hepatitis B in a clinical setting, because once it's user sharp, it's probably going to stay there for a very long time. If you go to your barber, they share, they are not sterilizing their cuts, especially those that use the blades. They are not sterilizing their blades. Then somebody with hepatitis B gets a cut, you come back 2 days later, you're just putting yourself at risk of getting hepatitis B.
That's why I always get a new blade whenever I get one of those Turkish shaves. So I just thought about that because I read that some time back. It's really, so, just to clarify, for HIV, if you have HIV on a doorknob or something, within 1 or 2 days, it can't stay there because HIV needs a human host to continue to survive. Whereas hepatitis B that we talked about today can be weeks on that doorknob. And if you have a cut, you touch that old blood or old infection, you then get it, not to talk of sharp objects. So this is really important for us to have an awareness of how we can sort of protect ourselves and how we can look into these things. Thank you so much, Dr. Mangawa, for such an excellent presentation today. And I hope we've all sort of benefited from having this conversation. I like the way we brought in research participation. I really want to emphasize that there are laws that protect patients, absolutely, about, in terms of research participation and things like that. So it's really important that when research comes up, as an ethnic minority person, please go and volunteer yourself. The same thing with blood donors and blood donation. I was just on the radio the other day, and the head of the blood donation thing in London was saying that they need more ethnic minority people to come and donate blood, and we need to participate more in terms of, because even in terms of transplant, some dear friends of mine who had health challenges and they couldn't find a Black person with a kidney, that had donated a kidney. I'm not saying, you should donate a kidney while you're alive, but sign up and say, if anything happens, let them have my kidney, and, that's something that at least you can contribute to society. Someone's pointing out to me that Cyndi Lauper is a performer at Glastonbury in 2024. Okay. Her song, True Colors, was inspired by a friend losing their battle against HIV. Okay, that's where the HIV connection. I wasn't sure how. I'm glad she's okay. I know she used to sing some good songs and all that. Thank you very much, Dr. Irvine. And I'm going to hand it over back to Kwasi and the CAN team. I hope we all have a good weekend.
Thank you, Dr. Joe, and thank you, Dr. Irvine. It's been a fantastic session, a lot of learnings. Thank you for taking us through hepatitis B, how the infection is caught or the processes for the infection, transmission, symptoms, the causes itself, and also the treatment. And yes, here at CAN, part of our work majorly borders on research, and we can't belabor the point. We have to turn up to the table. So as a community, we have to show up and ensure that research is demographically representative of the community we represent. Else, findings and clinical trials will continue to be skewed and won't have our interest represented in there. So I'll move on quickly to share my screen so that we go through the key areas of things that we'll be touching on for next week. So just a moment. Yes.
Wait, see, we can see your screen.
You can see my screen. Oh, okay.
You just pulled it down now.
Okay. Is the slide showing, please? Are the slides showing?
Not anymore, but it was showing earlier. Yeah, okay. Showing now. Yeah, perfect.
Showing now. Okay, fantastic. All right. So yes, our next session for Health Hour is childhood asthma, and it will be led by Dr. Mohammed Kamara. Just as you've enjoyed this session with a lot of learnings, we entreat you to tune in and to listen in. It has a lot of information, a lot of health advice, a lot of medication, responsive best practices that will be shared, just so we'll be able to handle the issue of in the area of our kids or our little ones. Yeah, thank you. We have our Healthy Hearts, which focuses more on nutrition, and we have a team of specialists who it's a bit of a balance, a physical aspect, and then nutrition in the terms of what we ingest or what we eat. So we'll have a 1 hour session that focuses on healthy eating. And then we also have a 30 minutes of physical session, and it will be handled by Dr. Habiba and our able Orlando Grant. And it's on Tuesday, so kindly tune in at 6:30 to 8 p.m. It's always exciting, it's always energizing, and it's always educative. We all know Cannes is known for flagship events, and we are coming up with a big one. This is the Black Healthcare Awards. What we've realized within the Caribbean and African community is that we don't usually celebrate our own, and it's not a paucity of a lack of leadership or success factors we're having there, but it's just a narrative, and Cannes is trying to change that. So within the healthcare sector, we are looking to honor and celebrate all those who have given their lives, service, labor, and sacrifice within the healthcare sector. So we are honoring doctors, nurses, clinicians, and all allied health professionals. And this award is specifically designed to honor them. We have patrons who have endorsed this award, patrons who are notable within the healthcare field, Professor Kevin Fenting, and a host of them. Just scan this QR code, go onto our website. Tickets are being sold. Get a ticket for your family, for your organization. Turn up and be present, and then just taking what we are doing as an organization and as we seek to honor and to acknowledge the services and work of people within the healthcare sector from the Caribbean and African community. It's just a way to encourage them and also to encourage the generation coming up to be able to take on the baton and then work diligently. We have our forebearers who have done that. Yeah. Our next event coming Tuesday is Black Britain Decides. This reflects the voting that will be taking place on Thursday, 4th of July, I believe. And continuously, we have to turn up and then vote and then make a statement that reflects a representation of our community within governance. We always complain about decisions, policies, practice not favoring us. This is our time and our opportunity to be able to change that narrative. So this program is specifically designed and it's called Operation Black Vote. And what we are doing is to encourage and then talk about why it's necessary to vote, and it will be held at the Wally Range Methodist Church. Just scan the QR code on the screen, and then we'll be happy to have you at the session. We have a host of services here at Cannes, and our advocacy team leads a legal drop-in session. And on the 11th of July, we are having a solicitor who has specialty in criminal law turning up. He'll be talking about, well, what it means to stay within the parameters of the law defined in the country we find ourselves in. And if you have some legal challenges with respect to criminality and some challenges that needs addressing, he'll be available to assist. The session is specifically designed as a question and answer session. So any questions that you have with relations to DBS challenges, these are the kind of forums that you have the opportunity to ask. And it's led by a Black legal solicitor. So it's a safe space, and you'll be heard and listened to, and solutions will be preferred. We have our diabetes peer-to-peer support within the north of Manchester. So if you have anyone or you know anyone who is within the diabetes space, you just get in touch, and we have that peer support group. So anyone taking care of someone with diabetes, if you are living with diabetes yourself, it is open to adults. You can be pre-diabetic. We talk about the best practices, how best to handle and manage diabetes, and a host of other things. So this is the kind of forum you'd like to be part of, or the support group you'd like to be part of. If you have diabetes or you know anyone with diabetes, kindly recommend. And it's a great opportunity to have people, share best practices among themselves and then provide that peer-to-peer support. So that covers it for this week. We'll be happy to have you join us again next week on our Health Hour. As we stated, it will be on childhood asthma And just as you found this interesting, educative, the session we'll have next week will be designed in the same fashion. It's filled with education, it's filled with learnings, it's filled with all these things that we provide week in, week out. So kindly tune in and join us next week. Thank you for your time. Enjoy the rest of your Saturday. Yeah.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.